really like to welcome all of you to our monthly webinar for the California Improvement Network. We're really honored and pleased to be able to have a couple of great speakers talk about accountable care organizations from promise to progress. There's a lot of activity going on both here in California and nationally, and it's exciting to talk and hear more about what's really happening on the ground. I'm going to start with a couple of housekeeping things. First of all, this session will be recorded and is being recorded, I think. The slides and the recording will be posted on our website within a week. So this is a common question. It's the answer sitting in the chat box, but it's also here on the screen. So a reminder is that we do ask that if you, because we have so many listeners on the line, we do have you all on mute. So we ask you to ask any question that you might have of the speakers in the chat box, which should be on the right-hand side of your screen. There's a little gray box underneath where you type in your question. You would send it to, ideally, I would send it to all attendees so others can actually see the question that you're asking, and then you hit send. I will be fielding the questions for the speakers to help them out. It's hard sometimes to speak and be looking out of the side of your eye at the same time. We also have a few polling questions on the bottom right side that we ask you to complete. 3 quick questions about who you are, just gives us a better sense of who's listening in and how we can speak best to what you're interested in. And so I now get to move us on to introducing today's speakers. Our first speaker today is Brian Hodgkins, who is the Executive Vice President of the Heritage California Accountable Care Organization and also leads clinical operations for the Desert Oasis Healthcare System. He previously spent 20 years in hospital-based leadership positions before coming to HPN, and he received his PharmD from the University of Southern California and completed his residency training at Kaiser Foundation Hospitals in Los Angeles. Dr. Hodgkins is an innovative clinician, educator, and advocate for healthcare access issues and has a practice interest in population-based health management, and I think you'll find him to be a real dynamic speaker. He holds faculty appointments at USC, Loma Linda, and University of Pacific. He'll be followed with and kind of tag teaming with Karen Driscoll, who is the Vice President of Clinical Services and Operations at Heritage Provider Network and the Heritage California Accountable Care Organization. We'll be calling it ACO mostly because it's a lot of words to spit out at one time. In this position, she's responsible for delivering value to the network through ensuring operational excellence in medical and clinical operations. And she is responsible for overseeing all operational activities, including medical service delivery strategy, clinical operations support, medical and clinical improvement program implementation, project management, and other duties which drive excellence. So you can tell she's got a lot of things on her plate. Over the last 20 years, she has served in leadership roles in hospitals, medical groups, health plans, and national improvement organizations. So she has a sense of different settings. And she has a master's in healthcare administration and business and bachelor's in nursing. So we've got a PharmD and a nurse here, so we've got some real clinical expertise speaking as well. So I'm going to pass this ball on over to Brian so he can speak. Come on, click. There we go. And he'll be telling you a lot more about what Heritage is doing. So Brian, I think you should have the slides as well as the mic.
Okay, thank you very much. I guess the ball is proverbially in my court now.
Yeah.
So a pharmacist and a nurse, it's like cats and dogs living together, mass hysteria. But today, first of all, thanks for inviting us to share our experience to date. We're 15 months into what many would call an experiment. We would prefer to call it an experience. And we're going to be sharing kind of where we started, how we got there, and where we're currently at. And then Karen will admirably tell you about some of our care coordination strategies and transitional care programs that we think will allow us to achieve the triple aim in which we've been so interested and dedicated in trying to achieve as part of this ACO. So from promise to progress. So this is just a general topic and outline of what we'll be kind of talking about today. And as a placeholder, I just wanted to discuss briefly here about the Pioneer ACO model and shared savings model or any other type of ACO model you're going to hear about. And a lot of questions to date have been, does the model matter? And if you don't know, if you're part of the Pioneer organizations of 32 like we are, there has been a lot of discussion lately about the most recent data and discussions with CMMI, and that we know now that 8 of the 32 Pioneer ACOs have achieved the 2% minimum savings rate, which allows people to get to population-based payment schemes. And the reality is we don't know who those 8 are. We internally may have an idea, but the reality is I liken this where we're at currently in the Pioneer ACO strategy to a poker hand. It's can't get rid of, we're all in the big blind at times. We're hoping some help comes on the river, which normally is data, and we're all in. So there's no way to get out of it now, but the idea is you're going to see in this experience and the experiment is that everyone here has best practice models, and whether or not you're in a closed system, if you own the hospitals and the doctors, does that matter? Is smaller population matter? You're going to see that we're a very extended IPA, geographically challenged, and a very large Pioneer ACO. And we'll see that that might actually have some differences in the way that we have to manage our lives across this continuum. And so is it experiment or experience? I would argue that if you start to read any literature and you read what the politicians are saying, they consider this an experiment. And in fact, you're going to see that synonymous with ACO over the next couple of years. But I think we have to take it all to heart and know that this is a learning experience for all of us 15 months in. And we're going to have to do something different and better because we all are in agreement here that the healthcare model and the way we pay for it and strategize care is definitely going to change. So as we get started here today, some would say, are we at a crossroads? And if so, which direction do we take? Or do we have barriers in the way? And I think people would say that the current monolithic delivery system is the biggest barrier, and the rigidity and fear of changing any payment scheme is really weighing heavy on those providers out in the various care scenarios across the United States. So I've always called the ACO the unicorn of healthcare. It's kind of a magical and mysterious and majestic beast, but we're not really sure if we'll see the success that we need, but we know that I would say right now this is too big of an experience to fail. And I think as we get along, we're going to see that all the 32 pioneers and over the 220 shared savings models, that we're going to get some traction in this, and we're going to be able to deliver quality and health cost reduction that we've been able to deliver in other markets. So we're going to talk about some of our engagement, what we've done with our doctors, what we've done internally as far as how we've contracted and what our strategy has been. And then Karen will then, as I stated, get into care coordination and talk about some of the best practices. And at the end of the day, quality is the true deliverable, which I think is going to be the winnable subject when it comes to, are we going to see the savings? So this is Heritage California ACO. We are a very large and geographically diverse group. As you see, we have 700,000 lives covered just in our commercial and MA plans across thousands of PCPs and specialists in 100 hospitals. So one could start to theorize that we have contracts or not contracts with 100 different hospitals. So it's going to be very difficult as we start to manage in the ACO model across numerous PCPs who may not know each other, various geographic areas that have small hospitals, big hospitals, rural facilities in them, trying to manage an ACO population which now numbers nearly 90,000. And although we're talking about the Pioneer ACO today specifically as a Heritage California ACO participant, HPN also has shared savings ACOs in both New York and Arizona. And although there are some nuances in the way quality is reported and the way the payment schemes are mediated, the bottom line is it's still triple aim. We're going to have to improve healthcare, reduce the cost of care, and improve population-based health. And that's really what the game is all about. So if one was going to start getting involved in an ACO or was going to pull the ingredients out of a cupboard to bake an ACO, what would you have to do? And so we were faced with this proposition now over 18 months ago. And you know, the ACO, the laws that govern the ACOs that were written, really it all came together pretty quickly with everyone trying to put their hat in the ring to become a pioneer provider. So one of the things that you had to do internally was just look at your current clinical systems, whether or not you had the administrative structure in place to deliver on these complex population-based dynamics, and then the data support to do that. And I think what we're starting to see is that data is everything, and data, we feel, and IT systems are probably going to be one of the most important strategic parts of any ACO. It's your ability to manage data, understand patient population shifts, risk stratification, et cetera. And we have a tool that we developed internally that really is helping us from the get-go on this one. The other thing that you need to look at is your track record of success. Just because you've done it in the MA population or commercial doesn't guarantee that you'll be able to pull this off in the fee-for-service world. Because the ACO kind of sits between the fee-for-service world and the Medicare Advantage world, and some people would call it Medicare Advantage Light, in that you don't have total control. You're trying to impart some loose affiliation of a network to your beneficiaries. And for the sake of argument, I will interchange beneficiaries and patients liberally here as a clinician. But the idea is we've learned quickly within the first 3 months that the Medicare fee-for-service beneficiary is truly a different type of patient. The other thing is, do you have care team in place? And these are care coordination strategies. And for us, because we have 10 groups in the Heritage Provider Network, each of us has to kind of do the internal measurement to see whether or not we have those resources available to start to do care coordination. And this is interesting when we talk about engaging the beneficiary population who has never heretofore been engaged in conversations about care coordination. Many patients are, the slide speaks for itself, 1 in 5 patients couldn't even tell you who was in charge of their care. So whether it was PCP or specialist. And then there's also a big disconnect between PCPs who think they know what the patients know their diagnosis and treatment plans in those patients who actually feel that they do. And as we started to engage beneficiaries early on in the conversation of their involvement in our ACO, we found that, those two things were very true, and something that we were going to have to address as we started to build a brand and affiliate those patients back to HCACO. The other thing is, in conversations with our providers, we started to have conversations that changed the dynamics from a productivity-based fee-for-service payment schema eventually to value-based payments. And whether it's a hospital, a different type of provider, independent practitioner, or group practice, these conversations need to be held early on, and they're very complex and sometimes very noisy. And lastly, among your last ingredients is, do you have a history of trust among those providers that you're already providing services with and for and are already contracted with? And so nobody gets into this game without having an idea of accepting risk, both population health management and then the ability to manage and measure that quality data, because we know, excuse me, after the very last meeting with CMMI, quality is everything. So what are the strategies for successful implementation? So our triple aim, besides the original, is focused on the providers, the patients or beneficiaries, and then the community. And in this slide, we're really addressing here how we start the conversation with providers. So if you were going to go out and start to recruit providers, and all pioneers can continue to recruit and contract with providers, and we understand pretty soon there may be an attestation process coming down the way, which would be a mechanism actually to grow enrollment specifically. So these conversations have been held, have been heard, and continue. So we started this conversation with all of our MA-affiliated, exclusive and non-exclusive providers, and new providers doing what we, holding town hall meetings. And this is just, it was an informal way to invite providers, potential and prospective contractable providers, to us. The other thing about this is the communication on the ACO, because it changes like the weather, needs to be frequent and in many forms. And so we have newsletters. We've also had discussions with the office managers, because in many respects, they will be organizing and be the communication with that provider once the contract's signed, and we're continuing to try to identify patients that they're seeing and coordinate their care. And then we've also used our physician group meetings, whether our physician advisory group meetings, et cetera, to promulgate that discussion about what's happening in the ACO. We've done something here unique. We have a fondness for universities, so we've sponsored ACO universities, and we continue to invite practitioners to them. And this year, in Performance Year 2, we have an ACO Master's Program University. And we use these in conjunction with other educational models that we use for our Medicare Advantage. And that would be our HCC University, our CMS 5-Star University, things that may not be applicable per se in the current ACO model, but may have some implications for the duals when that demonstration project starts. But the idea, though, is it does have some overlapping quality, and it gives us an opportunity to have a singular message when it comes to managing these patients and coordinating their care from the quality side. We also have to let them know that in many models, there's no downside financial risk. And as we start to talk to the onesie, twosie doctors of the group practice, this is important for them to understand that for us, Heritage California is doing all the heavy lifting, and that's a critical element of this particular message, and that we need to make it transparent and easy for them to participate. We want them to continue to see their patients in the fee-for-service world, but now we're trying to also have them understand that whatever they're doing for the MA patients, we want them to continue to do, although you're going to see some nuanced differences when we start to have conversations with those patients about the offerings of various services, some of which may or may not be billable events. And lastly, we've asked our providers to trust the relationship that we've developed over the last 30, 40 years in our HMO, PPO, and MA business lines. So this is a separate business line, and it needs to be treated as such, because these types of patients and the strategies that one can put forth in managing an ACO are vastly different from the way we may be able to approach them in the Medicare Advantage population. So here's some transitions in ACO that we've seen. Initially, the thought was, let's go out and aggregate as many practitioners as we can, sign up all the doctors that we can, thinking you get more lives, and in the end game, that would be beneficial for an organization. As we talked initially in the beginning, is that the model does matter. So as we start to look at the types of physicians you want to sign up, or at least contract with, even among the PCPs, maybe you're going to be thinking about specialists, even though specifically they don't participate or they're not aligned, they don't have aligned beneficiaries in this model. They are critical as far as managing some of the chronic disease processes that affect claims data and utilization. So for small solo practices, there's no financial risk to them, and we don't ask them to do too much. We try to do all the work for them and make it simple for them to participate. As we've started to go back and look at larger groups or specialty vendors, we've been more concerned about, do they have EHR capability? Can they demonstrate meaningful use? Can they share data with us if they have stuff internally, even though we're getting all the claims data through our QACO modality? And also, do they have any integrated or centralized care model themselves that can help us assist them in a consultative nature whenever that's possible? And then for what we have, you're going to find out we do have sub-ACOs, and these are large specialty vendors, and we would use Fresenius as an example of an end-stage renal disease vendor who manages a high-cost, high-risk population with us jointly with some risk. And large university-based health systems or hospitals that we've signed up as well to work with us, where we serve in a consultative capacity. We help coordinate some of their care coordination, but in the long run, these patients are affiliated with these entities, and it helps. It's definitely a win-win as we leverage the strengths of both organizations in trying to win this quality and cost savings game. So initially, we wanted a lot of lives, a lot of contracts, and as we get down the road more, we need to be a lot more judicious in who we're using, who we want, strategizing organizations that can help us do some of the heavy lifting that's required in managing 90,000 patients. The other thing that's critical, and this is the issue of developing physician leaders, and that I think we need to look at this benefit more in the future, and that we've done this obviously in the hospital setting. You take physician leaders and you let them kind of hold the conversations that influence other providers. And in the world of ACO, this is very, very important. So we've taken those exclusive guys, contracted PCPs who are leaders in the community, and let them carry on some of the discussion with us and help discuss with their colleagues what works in the ACO and why they should be a participant. The other thing that we've done is we've had to continually try to educate physicians on healthcare reform and where healthcare is going, and they are very opinionated on this topic and not always correct. So we have to be proactive in actually positioning them towards focusing on the inevitable, which is going to be population-based management and a difference in the payment scheme in the future. I think the ACO population today, 25% of Medicare beneficiaries are in the MA plans. We probably just have about 3 million right now in the ACO coverage scheme. I see probably 100% eventually getting into some sort of coordinated care system or model, however that looks, 3 to 5 years from now. Foster an enterprise-wide commitment to the ACO. This is the comment I made a little bit earlier, and that is, this is not something you jump into and say, we're going to overlay the ACO responsibilities on the existing Medicare Advantage provider network and or care coordination network. This needs to be a very focused team, because the conversations you can have with beneficiaries are vastly different. There is no network, there's no referral process, they don't want to be coordinated many times, and oftentimes we found that the critical event that put them in the hospital or got them to a doctor's office is the time when we're able to join them with a conversation that allows them to understand what we're trying to do for them and sell those benefits. And I feel, and probably it's widely felt, that CMS may have missed an important opportunity here in really selling the ACO to the beneficiary populations who are involved, because an engaged beneficiary, along with the care coordination strategy in all these ACOs, the synergy of that will probably not be seen until probably year 3 or 4, because right now we're really trying to do all the engagement and education of the ACO beneficiaries from our side of the fence. And we're hoping down the road, and we continue to have conversations with CMMI, that they'll be able to actually do some of the positive marketing of the ACO and the benefits thereof outside of an annual letter that goes to new beneficiaries. Lastly, we need to keep the process simple for the provider office. We have them doing so much already. Sometimes they feel inundated and incapable of managing the change imposed on them, just trying to make a living. And so we're trying to do everything we can to make the ACO experience profitable, but also efficient for them as we roll forward. And one thing that's important, and we've started to see, is that celebrate the beneficiary victories. We have over 1,000 patients now enrolled in various programs across the Heritage ACO. And as they feel that they're getting care that they need, care that they didn't have, they themselves become very vocal as far as telling the virtues of the ACO. And in fact, we've learned a lesson from other groups in that if you let these patients be advocates to other patients, it's a very effective strategy in messaging. And so we have a consumer advisory board that's mandated as part of the Pioneer ACO. And as we start to have these seniors come in and tell us what's lacking in their local healthcare markets, we hook them up with other unconnected seniors and beneficiaries. And we've uncovered all types of other organizations who can provide services that we didn't know existed in the shadows of our own organization. And so use these successful ventures with patients as a means to educate others. So let me just take a few slides here to talk about the compensation approach, because if you're not in the ACO or you want to get into the ACO and you're thinking, well, how do I get physicians to participate? What's a strategy for contracting? This is a very basic model of how we started out, and as I alluded to previously, we have made some amendments to our strategy from 15 to 18 months ago. We looked at physicians specifically who had a relationship with us, who may have been exclusive in our MA population, who had a relationship and had an experience positive with our ability to deliver on quality in the CMS 5 stars and in coordinating care for complex patients. And we basically said we'll take the first X%. So let's just say it's 5% of savings. given back to the doctors based on the savings that we would generate from each performance year. Any savings beyond that 5%, we would also divide between them after we recoup our administrative fees and also reimburse the equivalent amount that was distributed to the providers initially. The other thing that we didn't have in place, but probably needs to be really considered, in that quality performance as an incentive to the payment structure probably should be done up front, and we're revisiting that all the time, because as we're learning, this is an interesting thing about even getting into the ACO, in that the fee-for-service beneficiary in the PCP office really didn't have a mandate for quality measures that we see with the commercial and MA plans. And so there's never been the requirement per se to measure the PCP's output or effort on these quality measures. And so even though we want them to manage them themselves, the attention to detail sometimes gets lost in these patients who are tough to coordinate. So we're going back and revisiting that. And so if you have an exclusive doctor with an MA agreement with you, sometimes we might be able to sprinkle the benefit on that cap in order to get the same type of quality achievement in the ACO population per se. So which may be a successful strategy. We're still thinking about that right now. What about compensation if you're going to sign up PCPs and specialists? Virtually, we've approached them pretty much the same. And that first 5% of savings can go back to the providers. If we do better than that, we'll share that with them after we've balanced our books as well. Now, the large multi-specialty or specialty groups, we were talking about those earlier, like Fresenius. And these large groups that are sophisticated already understand risk. It may be acceptable to find out if they can take risk in that affiliation. If we get the population-based payment, then it would be of interest to go back and actually visit some of these groups, or start to look at other large organizations or specialty groups as a potential collaborator from a risk perspective. But in these cases, we benchmark against their own aligned beneficiaries. So let's just say a hospital, University Hospital, has 5,000 aligned beneficiaries. We can look at their benchmark, look at their performance year over year, less extra administrative and consultative expense, and then we can either give upfront bonus payments or not against future offset shared savings, however those seem to work out. And then they may or may not share in downside risk. So there's strategies and looking at either larger organizations, hospitals, or specialty providers in contracting down the road as each performance year crosses. This is a typical engagement scenario with our providers. It's a conversation up front about what an ACO is, which is difficult at times. We need to remind folks that it's not an HMO, and for some reason, you'll see that even on websites of many pioneer organizations. Even CMS has to clarify that the ACO is not an HMO. And that they're still fee-for-service. It doesn't get into any of their the way that they're reimbursed. We still want them to see their patient as often as they need to. And in fact, oftentimes, we are coordinating bringing these patients back, or beneficiaries back to the PCP after a hospitalization or acute event. We explain the beneficiary alignment process, which is very difficult at times. And if you read the law on that, the attribution models for both shared savings and the pioneers are tricky, and then some alignment actually happens internally as well. We explain the benchmark, the targets and the goals, and how they can be achieved. And then there's no downside risk. There's no capital that we ask for. If we don't make money, there's no shared, we don't ask them to write us a check. And the most important thing is that it's still a PCP-centric relationship, that they are still the captain of the ship. And they have told us many times, because many of them don't admit patients to hospitals, that they appreciate us coordinating the care and bringing the patients back to them after them being hospitalized, and seeing a provider on a hospitalist team who also has a private practice, who is more than happy to steer those beneficiaries to their practice post-discharge. So it's been a win-win, and a conversation that is improving daily. Essentially what we do is we take that 5% or 10%, whatever your contractual desire would be. We look at their CMS reimbursement, and so if they made $30,000, it'd be 10 times that as their potential upside bonus for participating. And then if we do better than that, they get an X% as we've already pointed out, after we reimbursed ourselves the equivalent amount. No downside risk, and we've also been very strategic in trying to organize and offer them a strategy to be at least electronic health record, at least participant. In the Pioneer ACO, 70% of your providers need to be EHR at least compliant. And that's very important because, as we talked early on, the savings from the shared database and the ability to mine that and share those records across the continuum are really tantamount to success or failure in this particular strategy. And then the other thing is that we offer them the same types of programs internally that their MA patients get. And we think that this is actually going to expand as more conversations get into whether or not ACOs will be allowed to offer palliative care strategies, et cetera. But all of our disease management, all of our care coordination, our pharmacist-based med management programs and reconciliation, they get all of that, the screening programs, all of that at no additional cost. And at the end of the day, the providers feel better about, they get better monitoring, the communication flows to and from the office much more routinely, and they're happy with our ability to keep them up to date on what's happening in their population. So before I turn it over to Karen, as a segue, I just want to kind of recap some things as we move into the care coordination piece of it. So we talked about the importance of data and taking on risk and managing that, which I'm sure everyone on this call is familiar with. We've learned that our QACO, which is our internal one-stop shopping, claims, data management, disease management, and the ability to risk stratify is critical to identifying patients so that when one starts to look at the resources required to provide services for 90,000 ACO beneficiaries, it sounds extremely daunting and it sounds extremely expensive. But if you have a very good risk stratification mechanism, one quickly sees that you don't need to reach all 90,000. You probably only need to reach about 10,000 of them. And of those, you want to look at those high utilizers, those with complex and chronic disease processes that are that influence the quality measures. So specifically, diabetic would be an excellent example. 6 measures in the quality, it's an all or none. And so we need to reach them. We need to improve that population-based health. But once again, you can meet the 2% MSR. If you don't meet the quality measures, you're going to be in trouble in the long run. Beneficiary engagement is critical to care coordination. It's also critical to the success of an ACO. As we've alluded to, these beneficiaries have never really been reached out to or try to be onboarded into a program that speaks about care coordination, improving their wellness and maintaining their health. We've done all kinds of social events. So in an ideal world, it would sound good if a frail and sick Medicare patient would find care under one sheltering umbrella organization such as ours. And it sounds good, and that's really what the messaging is. And so it's kind of disheartening sometimes to hear what the physicians have to say who are not part of an ACO as to what the ACO is really all about. The bottom line is there's healthcare needs and there are social needs among these beneficiaries, which I think, and we have found, are very important to engaging them, keeping them engaged, and starting to build a brand so that they start to think of your ACO as the place that they go for their care and not just the place that happens to provide care at times. Quality over quantity is an ACO theme, so those of you in the ACOs, regardless of shared savings or Pioneer, know that quality and the change from the quantitative efforts of healthcare needs to change. And you know, our motto within Heritage Provider Network is, you know, turning care dollars into cure dollars. This is really turning acute care dollars into wellness dollars. And that's a huge part of this, and it comes to education across the entire organization, not just those involved in the ACO team. We all need to understand the difference between MA and ACO. I think everyone does that. The patients don't understand that all the time. But the idea is these patients still can see who they want to see, and there's no network and there's no referral. And so we are managing patients right now. We're accountable for patients right now who are being seen all over the United States. So even if they're not in our backyard or in our geography, you know, they have the right to see whoever they want, and you need to give them options, but they have the final decision-making capacity, which engages us to understand that the PCP really is critical in influencing patients to make good choices about where they go for care, and hopefully it's within your organization. And finally, as Karen gets ready to step onto the microphone, the transition and care coordination delivery, she's going to talk about these elements and how critical those are to us improving the overall wellness of the populations that we're trying to manage. And as I said, it's not the 90,000. It's going to be select patients in that population that really need to be touched and touched often for us to actually gain traction in both quality and in reducing some of the costs associated with them using the emergency room or expensive care sites, hospitals, etc. And I would just add that as we start talking about transitions between hospitals, there are pioneers that have hospitals, and so it's kind of a closed system. It's a beautiful world. In our world, we've had to go out and educate hospitals about the importance of collaborating with us so that we can help manage their patients, decrease readmissions in those targeted diagnostic groups that can cost them money. And it's a win-win for both sides of the fence. Hospitals in the past have always been business-oriented towards keeping patients. Butts in beds is what we used to say at our hospital. But the idea now is to work with hospitals to find ways in which we can improve all of their quality measures while they're helping improve ours as well. So Karen, I will turn the microphone over to you. Did you want to drive the slides, or did you want me to do those for you?
I think she was going to have you drive. Go ahead, Karen.
Okay. All right. Well, listen, thank you very much. We'll be available for questions at the end, and I will advance the next slide. Karen, take it away.
Oh, one more slide. Hello? Brian, one more slide.
Yep.
One more slide. Okay.
This one?
Yes. So I'm going to
okay.
jump onto Brian's coattails and hang on very tightly, because he actually covered a lot of some of the discussion points I wanted to go over, so that's good. That means that I'm going to reiterate and drive home critical elements that will help you build and or be successful for your ACO. A couple of things. I'm going to talk about best practice and care coordination, but the distinction needs to be made between, yes, these are best practices, but these are also very core key strategies that you need to put in place to ensure that your care coordination system is effective, and overall it helps you meet that triple aim of cost, quality, and improving the experience. So that said, jump to the next slide, Brian. So we're going to talk about reducing transition, and Brian talked about this very eloquently earlier. Data. It's all about data. Everybody who is an ACO or who is thinking of applying to be an ACO is going to receive some level and some form of data from CMS. It's absolutely critical that you take that data and you chew on it 6 ways to Sunday to identify your beneficiaries, identify your patients that are at high risk for transition. And Brian said it perfectly. If you've got 1,000 beneficiaries assigned to your ACO, odds are it's not realistic to actually try to wrap around and manage all 1,000 beneficiaries. It's not cost efficient, and it's not going to help move the agenda forward. So what you have to do is you have to take the data that you receive, run it through an algorithm, whether you have an internal algorithm that you've built. There's a lot of vendors out there that have platforms where they can perform data analysis for you. That's the type of tool that you're going to need, so you have an algorithm to spit out who's going to be your high-risk beneficiary. And you have to determine what's going to be a high-risk beneficiary for your particular organization. We have an internal tool. That's the ACO tools and strategies that we've developed over a couple of decades that help us tease out who are the beneficiaries, members, and our patients that we truly need to wrap our care coordination systems around. So to reduce the transitions, you absolutely have to look at your data, and as a minimum, you have to look at this data at least monthly. Most of us get monthly data loads from either our health plans or our employee groups or other partners in business, but it's extremely important that you're looking at your data at least once a month, scrubbing it and stratifying it to identify those high-risk beneficiaries. That's one method. The other method is that if you have your list of beneficiaries, you need to reach out and perform some type of comprehensive assessment of those beneficiaries, utilizing both the historical data that you're going to receive, but also you could do a telephonic assessment of the beneficiary. You can send out something where they can provide you some baseline written information about themselves. We prefer that much more comprehensive face-to-face assessment, but it's really a multi-pronged approach. I mean, sometimes it's not cost-effective to try to bring everybody into the clinician, into the medical home, so you kind of have to wrap around your support system to get that information from the members. And then I'll go back to the fact that whatever data that you're receiving, make sure that it includes claim information. If you can get it, you need pharmacy information, you need laboratory information, you need information for the medical records for the physicians that are contracted or aligned with your ACO. You want all of this information, and if you're lucky enough, perhaps if you've had a managed care product, you may have some referral management information. So the whole point on this particular slide, reducing transitions, is getting your data, synthesizing all of that data into some type of actionable algorithm where you can stratify your population, identify who do I actually need to reach out and touch. So you can go to the next slide, Brian. So managing transitions. Managing transitions kind of goes back into the reducing transitions, except for this is where, okay, you've identified your high-risk beneficiaries. So we're going to make the assumption that you put your population through that tool. You've identified them in whatever manner you feel is reflective of how you want to set up your management or outreach systems or support systems. For us, we use high, medium, and low risk. It seems rather elementary, but there's a little bit more to it than that. But I mean, it's a high risk beneficiary, medium risk beneficiary, and a low risk beneficiary. And once we've done that, now we can begin to see, oh, okay, so we find out a patient or a beneficiary is in the system. We've already stratified them, and now we know that one of our beneficiaries is actively engaged in the care delivery system. So what we do, and Brian talked about our provider network as a whole. We've been around for a little over 30 years, and so I know when my beneficiaries enter into an acute encounter or a skilled encounter or a rehab encounter. So I wrap around, if I have an inpatient hospitalist team, if I have inpatient case managers, they go in, introduce themselves to the beneficiaries when they're in the hospital, and help provide transition support services, working within the parameters of the requirements of the hospital and or the requirements of their licensure. That's when the beneficiaries are in the hospital. So the key to that one, obviously, you're asking yourself is, well, you know that the beneficiary is there, so you can manage that transition. But again, for us, this seems intuitive because we've been doing it for a long period of time. But for those folks who maybe don't have that system in place, you have to think, how do I put this system in place so when they do end up in the delivery system, how am I going to know they're in the delivery system, and once they're there, what's the most effective way for me to manage them? For us, again, we use our inpatient teams, we use assigned case managers, and if it doesn't occur in an inpatient setting, if it's just an outpatient setting where they've gone to, I want to say like a outpatient rehab or to a specialist, I use another system which I'll talk about a little bit later on how we deal with that. So, but for the purpose of managing transitions, the primary takeaway for any beneficiary in your care coordination system that you've identified them, you're actively either monitoring the transition through the system or supporting the transition through the system. The two actions alone that will reap the greatest reward are that you review, once that patient has discharged to the next level of care, the next lower level of care, that you review whatever follow-up instructions were given to that patient before they transition to that point within 72 hours. Ideally, the first 24 hours. In a perfect world, the first 24 hours. But in reality, if you manage to touch that beneficiary or patient at that next level of care within 72 hours, you will be able to catch any gaps that may have occurred during that transition point. That particular point, too, particularly if they've gone back home or back into the community-based services, you want to focus on what's their ability for self-management. So that's kind of a face-to-face assessment, and sometimes you can do that telephonically. Sometimes you can use a home health agency that may have been sent out to the home. For us, we're fortunate enough where we have both visiting physicians and clinicians that can go out into the home, and so we have that particular system. But think through that logically. If you don't have that, then whoever are the eyes in the home, those are the people or those are the individuals that you want to work with to communicate that information back to you. The other element that's going to be critically important, medication reconciliation. This is also one of those quality metrics that crosses all lines of business. Medication readmissions are one of the top 5 drivers of readmissions in unmanaged populations. In our particular model, we have a very, very mature and a very robust pharmacist-driven medication reconciliation program. And that kicks off, sometimes it kicks off within 24 hours of the discharge home, but if it's performed within at least 3 to 10 days post-discharge or, post-transition to a lower level of care, critical element in preventing readmissions and providing that needed care coordination, closing any gaps of misunderstanding. And it's interesting, Brian as a pharmacist could probably even speak more on the nuances of that program, which we may do just completely separately. We could do a whole separate conversation just on the pharmacy-driven programs alone. But those 2 elements: follow-up instructions within 72 hours, follow up with the patient's caregiver, with whoever is going to be accountable for the patient, and do medication reconciliation with 3 to 10 days. Those 2 elements alone will help drive a tremendous increase in the care coordination opportunities. Again, for us, we use some of our own internal tools. We use our inpatient management and discharge plans. So this is where we get a lot of this data from. So that's what those bottom boxes are going to show you. Do you want to go to the next slide, Brian? Supporting transitions. So, again, it's really funny when you're teasing out and you're trying to figure out what are the true takeaways that you want people to understand to really drive effective care coordination. It's hard to tease out singular elements because they all flow kind of seamlessly one into the other. So you've used your data to identify your beneficiaries. You've identified beneficiaries that are actually in the hospital that need transition management or in skilled facilities that need transition management. Now, what's the key in actually supporting those transitions? Again, it seems for us kind of intuitive, but it's very, very important when you're transitioning these beneficiaries from one level of care to another that you share all of the bullets that you see here. Don't make an assumption that they know what treatments are going to be continued or discontinued. Don't make an assumption that they understand that you're going to be leaving here in 24 hours. You may potentially be in a skilled nursing facility for a week. I mean, clarify in writing, provide this to the beneficiary, provide it to the beneficiary's caregiver and or family member. This will all be in writing to the care team, which is kind of what we call our wraparound care coordination program, our interdisciplinary team, and any community-based organization. And this is particularly for a patient that may be receiving those supportive services from your community or your state organization. Make sure everybody has a very clear understanding in writing of what are all those elements involved in supporting the transition, and critically important, provide a 24/7 contact person. We call them patient ambassadors, we call them care coordinators, you can call them case managers, but having that individual who is accountable for that beneficiary available 24/7 will help identify any potential gap, any potential readmission, any question that anybody within the care team has, you have to be able to go back to that one individual who has access to all this information. In order to make that happen, you need to consider what type of IT/IS infrastructure do you have within your system now, or if you're considering an ACO, you need to have some type of infrastructure where you have complete transparency and 100% communication that's biodirectional. It's not impossible to do it strictly telephonically, but it's a whole lot easier to do it if everybody can log into a portal and or a tool, a website, where they can see all the communication, all of the transition strategies, anything written that's specific to this beneficiary. Again, so the takeaway for this one, 24/7 care coordinator, and put everything in writing regarding the transition. There's no detail that's too small. People remember about 10% of what they're told in the hospital when you're transitioning them to a lower level of care, or from a skilled facility transitioning them into home. And we as healthcare professionals throw a lot of information at patients, beneficiaries, caregivers. So it's inherently important that you provide also everything in writing and provide it to the entire care support team. So there's no misunderstanding as to what's the level of expectation here. We can go to the next one, Brian. So identifying unplanned transition. I kind of alluded to it a little bit earlier. So how do we know that the patients, our beneficiaries, are in the hospital? And Brian actually pointed out, our beneficiaries can be anywhere in the United States and have an acute encounter, an emergency encounter, a skilled encounter, and we're notified. We have a refresh rate every 15 minutes. So every 15 minutes, we get a new data feed of our beneficiaries and any encounter that they've had in the system, both acute and ambulatory. The system that we use is called Passport. I believe there's a couple of other systems out there that are available to provide you with this information. This particular element in and of itself is the singular, most critical element to help us say our high-risk beneficiary, or any beneficiary, has now entered into the system. There was an ambulance claim, or there was an ambulance call. This patient was in the ED. In other words, it gives me that access to a level of information I never would have had before. Everything would have, if I have to wait for the claims to come in 30 or 60 days later, I've lost 30 days worth of opportunity to identify and manage that transition. And within that window, that opportunity of gaps and fragmentation of care are fraught. So the whole point behind a coordinated care system is to preemptively get in front of the coordination process. So for us, if they have an ED encounter, hospital, skilled, long-term ambulance, I'm getting that information real time. Somebody else did at one point after I did one of these discussions came up to me and said there's about 2 or 3 vendors in the United States that can provide this information, and if and when I do get the names of those, I'll make sure that I pass that on to the folks here on the call. But I don't have that off the top of my head. This one, so timely reports. I mean, it kind of makes sense. How can you manage what you don't really know? So this is how you know what's going on with your beneficiary population. So next slide, Brian. Brian talked a lot about quality and how quality is the job one. If we can drive the cost down and we can improve the experience, but we don't truly improve the health outcomes and the health processes, did we really achieve success across the board? So when Heritage put their system together, we thought, well, in order to understand that we are truly effective, we have to have some way to measure our performance. Same with you guys. If you're going to put these systems into place or launch an ACO, make sure that you have a methodology and reporting methodology to monitor those elements that tell me, is my program effective? Are my care coordination systems effective? Am I communicating appropriately to the providers about the care that the beneficiaries are receiving? So for us, we track all of our admission and ED statistics, both planned and unplanned. Particularly of importance for ED and ambulatory admission statistics are, if I had a beneficiary in one of my programs, and Brian talked about some of the programs that we have available within our system, it then becomes a failure of my system if I have a beneficiary that ended up with an untoward admission in a hospital, if they were already on one of my very high-risk case management or ambulatory case management programs. So it's important for you to track those elements to ascertain the efficacy of the program and the system you're going to put in place. Care plans and transition measures, that tells me, is my team timely communicating those transition elements when the patient moves through the care continuum? That's an internal measure that I check to, and that's kind of what I call an operational production measure. The clinical measures, the chronic and preventative, again, these are the quality measures that the Pioneer ACOs are held to. Actually, all ACOs will be held to quality measures. This is that encompasses both clinical, chronic care, preventative care, patient experience, the HOS surveys, those longitudinal surveys. So for those of us that are familiar with CAPS and HEDIS, that's what these particular measures are. We have a very, very, very mature program where what we did is we launched our ACO quality outreach interventions based on what we had been providing in our other populations. And we found that the practice of medicine is the practice of medicine. If a patient needs an immunization or a pneumococcal vaccine, it doesn't matter if they're in the ACO. It's across the board in a population. So very important that the folks who have not done this or have not had experience with collecting and are providing and tracking the quality measures either work with a vendor who can provide this service for you or look to develop this critical success element internally. I call it behavioral health measures. I pulled that out of the clinical measures, but it still is one of those quality HEDIS measures. And no program will be effective if the beneficiaries aren't allowed the ability to provide you feedback, and the providers. So you have to have within your system the ability to elicit feedback from both the recipients of the program and the stakeholders that are involved in the program. Because the only way you're going to make your program effective, your care coordination system truly work for you, is the people that are involved in this have to tell you what works and what doesn't work. And then that's that constant, quality improvement process across the board. We're very lucky in that within our homegrown systems, we have a couple of tools called Q Analytics and Q Metrics that help us track those. And these are web-based. These are web-based tools, and so anybody within the care team that has access can look at any particular member or any particular measure and track progress to that goal. So I think I'm done. I think I'm going to toss it back to Brian and let him do a summary of our discussion.
Okay. Thank you, Karen, for your insight and input. So some of the takeaways, trying to talk about the success and the experience and the progress of a Pioneer ACO in an hour is difficult to do, although we've attempted to do it. But some of the major takeaways is communicate at each level of the organization. This is providers. This is also your beneficiaries, and it's also within the community. And what I mean by that is your hospitals, all care providers who may not be contracted, but you want them aligned at least with the common goal of improving the health in the community. You need to educate your providers about ACO programs, and this is a constant conversation that needs to be had because, as I said, the ACO, the rules, the regulations, the data changes quickly, and we're always trying to achieve something that really has never been achieved before. And we didn't mention, but the quality measures in the ACO program, which although they're almost identical to the CMS 5-star, exceed really the percentages. It's 90% on each of those, and it's inexcusable. It's not 87 or 60% for mammography or 75%. It's 90%. So the thresholds are set high intentionally, and they're imbued by law. So quality is everything, but we need to educate our providers and make it simple for them to be compliant and to help us win this total triple aim program. And then the quality, we've talked about that. Without quality, whether or not you meet the MSR, you save money, you don't improve the health and wellness of the population. Even if you are allowed to stay in the game, you're going to be operating at a discounted dollar for services rendered. So the only way we all succeed, including CMS and the United States really, is if we actually can improve the care and the outcomes of the populations within the ACO model, shared savings, commercial, Pioneer, you name it, because in the long run, that's where the savings are going to be manifest. So that's really all we have today. Thank you for your attention. If there's any questions, we'd be happy to answer them to the best of our ability, if we can. So if there are any questions, I guess we would let our facilitators pass those along to us.
That's fine. And actually, there's one quick clarification question. Thank you, first of all, to Brian and Karen for a wonderful presentation. And please feel free, all of you listening in, to type in your questions. Here's a quick one, which is, how soon does Heritage follow up on medication reconciliation after a patient leaves the hospital? She thought that maybe Karen said 24 hours, but she wasn't sure if she heard it correctly.
Are we off mute? Yes.
Yes.
You did hear it correctly. In those instances, maybe we're in the rural areas where we have a hospitalist or we have a care team, it would be a 24-hour follow-up for medication reconciliation. But I would venture to say that the majority of the time we're somewhere between 24 to 72 hours. That's the window with which we've set internally as the benchmark.
Great, thanks. Here's another. There's another one here, which is, you talked about using docs for home visits. Do you also utilize one of these kind of ambulatory ICUs, kind of a comprehensive team-based, site-based care, or an extensivist program? Did that question make sense?
Yes. Yeah, I think if I'm clear, the question is asking, yes, we do home physician visits using home intensivists or ambulatory intensivists. We also use a range of physician extenders for home visits. Sometimes we have a home health agency. We use our home health agency. So I don't know if that answers the question.
Yeah, and I think the question is specifically whether or not you have like a separate clinic, kind of similar to a CareMore style model, where you actually have a clinic that's specifically for follow-up after hospitalizations, for example.
Oh, absolutely. We actually have ported that in every region we're at. If we're lucky enough to have a staff model, you have to understand a little bit about Heritage. I've got both, I have some groups that are very small staff models, but the majority of them are staff models with wraparound IPAs, and then the other half is 100% IPA. So what we've done is we've established high-risk clinics in certain areas where we want to drive the patient to high-risk clinics within 24 to 72 hours post-discharge if we can't get them that immediate appointment with the physician that they want to see. Remember, these are beneficiaries, so I can't tell them where to go. I can simply offer them the opportunity to go into my high-risk clinic. With my managed care population, absolutely. So the great thing, too, is I'm linked in, my medical records are linked electronically, and or if they're not linked electronically, I will ensure that from the time of that visit, within 24 hours of that visit, the information from that practitioner gets to the beneficiary's aligned physician or whomever the beneficiary wants us to send the information to.
That's great. And given that they're not assigned, it sounds like in some cases it's the beneficiary who actually has to tell you who to send those records to. Is that correct?
Right. Well, we will tell them who we show from CMS, who CMS has shown us who their physicians are. And I think Brian touched on it. It's really interesting. Some of these beneficiaries go, I haven't seen that doctor in over a year. I actually think it's Dr. Smith, my cardiologist. He or she acts as my primary. So send it to Dr. Smith. We'll send it to both of them.
Sounds great. Thank you so much. We've gone a few minutes over our allotted time, but you have provided such a wonderful presentation and provided us, I think, a lot of insight on the great work that you're doing at Heritage. So thank you all very much, and for those of you still on the line, please don't forget to fill out the little poll at the end and give us some feedback on how helpful this call was. Thank you again, Brian and Karen.
You're welcome.
Yeah.
Take care.
All right.
Bye-bye.